Good evening, everyone. Thank you. I'm honored that you are with us on this webinar tonight, and I've got a lot of information. I've taken pretty much a full day lecture, and I've tried to condense it. So there's going to be a lot of things I'm going to probably just kind of skip through. But let's get going. Just to kind of go back from what we did last time, just as a little bit of a reminder. Remember, in implant dentistry today, there really is two ways of doing it. There is the traditional way, Brandemark way, 1977. I'm not going to go through everything. Basically, you're finishing these cases from extraction to final crown in 8 months to 12 months in a three-step true process. We talked about what is also known as immediate placement, known as a stage one in implant dentistry today. That was formed about 1989, and we're finishing those cases about half the time, anywhere between 3 and 6 months. And so that's kind of how it's being done. But we also looked at what are the problems with immediate placement, and do we still have issues? It definitely has gotten better, but can we actually do it even better? And that's where the all-in system, and that's what we're going to be talking about tonight. And I'm going to be showing examples of what that is. But what I would want to start off with is the number one problem with even immediate placement, especially when you extract and you wait, is what happens to the bone. So I got sent this by Marius, who works with me, and I'm going to introduce him later on. He showed me this video, and I had to present it to you tonight. So what this video is going to show is it's an animation, but it talks about what happens when we don't have teeth that stabilizes the bone. And so what's going to happen is they're going to extract a premolar and a molar, and then you're going to see what truly takes place. You got to remember, the fastest amount of resorption takes place in the first 6 months. So if we place implants, we can stabilize it. If we don't stabilize the bone, then we get more of a resorption. And then we're compromised on the size of implants. If we don't get it to it fast enough, we got to use smaller implants. It's not as stable. It's not as good. And then if we let it continue, what ends up happening is we get to a point where without a bone graft, then we just don't have enough space. And we know that a bone graft is never going to be as good as what was originally there and when we had great bone. So I can't emphasize enough the importance of saving bone. And the best way to save bone is to be able to place an implant and a final abutment or temporary abutment day of surgery. So in today's world, there really is 3 stages of implants. I talk to patients like this. So it's not just a 2-stage and a 1-stage. There's 3 stages. The 3rd stage is the traditional way. Again, takes 8 to 12 months. A 2-stage is that 3 to 6 month. And then the 1-stage are also known, and there's a lot of different ways of being able to say it, but it's a one and done process. 0 bone loss, that type of a system where you're placing the implant, something that holds the socket. That's the key. How do we hold the socket so that things do not collapse? And the best way, the most accurate way that we know of today, and being able to finish these cases really with a PMMA day 1 is the way we're doing it now. We're not even waiting 10 days. The best way is with the all-in system. So what I'm going to do is I'm actually going to show you this surgery was done this morning. This is what I did this morning. I worked on this patient, and I've sped this up. About most of it is about 4 times, so it's going to go through this pretty fast. But this is what we do, and we do it every single day, just about every single day. And this patient is losing number 10. I'll show you some pictures of what he had to begin with. You see the drill sequence that is taking place. So this is what he presented to us. We went through the planning. We went through, there's a very specific way that I extract teeth with periotomes. to try to make it as least atraumatic. There's no such thing as an atraumatic extraction, but we can get really close. The main thing is we have to be able to support that buccal bone and make sure we don't crack it in any way. Here is the bone graft material. I'm going to show you what we're using for bone graft. I told you that last time. I'm showing you the different components that we can use. We've got the final abutment, the temporary abutment, and the PMMA. The best way to be able to put in the final abutment is you put it in your PMMA and then you seat it. And so it's so accurate right from the get-go. I didn't have to change anything. That PMMA goes directly right down, and it's actually stays in that. There's no screw in it right now. It just stayed exactly where it needed to be. We screw it down. We put our PMMA on it. Hold on. How do I get out of that screen? Oh, okay. And then you can see the abutment. Here is the final X-ray. This was done this morning. All of this was done this morning, and that's what we did for our surgery today. And you can see the final, this is what he's going to walk out with. Today I'm checking the occlusion, making sure that the occlusion is good. He was thrilled when he was done. And that took a total of 33 minutes. I was thinking about it earlier as I was going through this surgery. What this gives me is an ability to be extremely confident. And I have to take probably, I'm going to guess 6 to 7 less x-rays because I don't need to take x-rays all the way through. I'm confident that it is going to be exactly where it was planned from the very beginning. I don't need to take as I'm going through the surgery. So it's a very, very fast process. This is quicker than a lot of times a crown prep. So 33 minutes from start to finish. That's putting betadine on the outside of the face, inside, everything that we do. This took me exactly 33 minutes. This is the bone graft that I use now. I mix it a lot of times with cortical bone. I think this is absolutely fantastic from GC. I'm going to tell you, I was a huge skeptic of anything that was synthetic. I just didn't believe in it because I never saw a synthetic that actually worked. I can't tell you how many times I went back into a synthetic site and it was like there was zero bone. It looked great on an x-ray, but there was zero bone. Not only am I getting great bone adaptation, but I'm getting the gingivus for some reason actually loves this stuff. And I'm getting a better gingival response with this bone as well. Now it's a little spendy. We just ordered it today. And as I was preparing this, I saw the invoice and I wanted to show you. This is exactly what I ordered. I ordered the 2 grams of the medium. And for some reason, they don't sell it in a 2 gram for the small, but I ordered the medium and small. You need both, but around implants, I would recommend the small. In big areas, you're going to use medium and small. And then in a socket or in a sinus lift, you can use the small or the medium. I really don't like the large. The large is really large, and that would be good for a very large defect. But this is what we do. And if I need to add to it, then I just use cortical bone. It's wonderful to use. It's very hydrophilic. As soon as blood hits it, it just literally soaks up the bone. It's a great product. So let me go through, I'm going to go through a couple cases with you, and I'm going to show you kind of the whole process of the all-in system here. So we've got this patient that came to me. She was referred from another dentist because she had veneers done and she didn't like her veneers. As you're going to see, I think they actually were pretty good veneers, but she wanted something better. He went, I don't think I can make you happy. And so he ended up sending it to us. As we were going through her exam, we noticed that she had pain upon percussion and palpation on tooth number 5. We did a CBCT. We took some x-rays. tooth number. Here's what she presented to us. Again, the veneers looked, in my opinion, pretty good, but she wanted a little bit of improvement, and we thought that we could do a little bit better job with a little bit more realism, and she also wanted to lighten up her teeth and really make them white. So this is what she presented with. This is her PA. If you look at her PA in the mesial section, she's got an abscess right on that mesial section, and she also has a little bit on the lingual root. But what we noticed is, as we were going through the planning, is that, if we take this tooth out, she will literally have no buccal bone. It's going to break. There's no ifs, ands, or buts about it. That root goes right to the very edge. In fact, you can see there's just a little triangle of bone in the occlusal aspect of it. And then on the root section of it, what you end up with is this root that's sticking almost, that's what's sticking in the buccal section of it. So I can't extract this tooth, and we need to do a PET. So we decided that we needed to do a PET. These are the things that I need to be able to do the planning. I've got to do a CBCT. I also need a good scan. You can take impressions, but they're just going to take your impressions and they're going to get a scan anyways. They need a digital model of this. And then we always send pictures so that the designers can see who they're working on and kind of get an idea of the process of who we're working with. I want to introduce you to a great friend of mine, Marius van Tonder, and so we're going to play this video, and he's going to show you kind of what he does on the designing aspect of it.
Good day, everyone. My name is Marius van Tonder. I'm the Director of Technical and Clinical Affairs for Biotech Dental USA. I am also the one who will be doing the planning and the designing of the all-in cases. Dr. McRae asked me to make a short video of what we do on the planning side, and also to show you what your involvement is in the process. He gave me 5 minutes. I'm sorry, I'm going to take 10 because there are a couple of things that I would also like to just point out. So for you to submit these cases to us, you need to send us a CBCT, and you need to send us upper and lower STL files. If you do not take digital impressions, you're going to send us the upper and the lower impressions, or the upper and the lower models, and all we are going to do is we're just going to convert them, and we are going to end up with the STL files in any case. Now, the important thing to remember with the CBCT, it has to be open as in out of occlusion. Couple of reasons for that, but the main one really is when we do the alignment of the STL file with the CBCT, we need to have the cusp tips visible. Now, you know, when a patient is in occlusion, we do not see the cusp tips or the incisal edges typically, so that makes it impossible for us to do a merge of the mandibular STL file with the CBCT. So please make sure that your CBCT is always open. Also make sure that you have as little scatter as possible. What we do is very accurate, so we want to make sure that the alignment of the files are very accurate. Okay, so once we've done the alignment of the upper and the lower STL files to the CBCT, the next step is going to be, we're going to do segmentation. And what do we mean by segmentation? Segmentation is just a fancy word for saying that we are going to cut out the crown from this model. So once we've done that, this is what we end up with. Any software can really do that, nothing fancy about that. With the NemoScan software, we can go further, and we can segment the root as well. So we will end up with the let me just switch off the gingiva. So we are going to end up with a tooth with the roots, the complete tooth. And we can now subtract that or virtually extract that tooth from the model. And this is what we end up with. So now we have the exact gingival contours of this socket. And this is what makes it amazing, because this is what we're going to use as a reference when we design the custom abutment and crown, or the custom healing abutment when we do it all in two stage. So once we've done this, now we can proceed to planning. So I'm gonna go to layout implant center is good. And let me just add the implant that was planned before. So we are going to plan this case. There's a couple of things that we look at, apart from the normal rules that apply when we do implant planning, like maintaining distance between the adjacent roots, staying clear of the sinus, staying clear of the mandibular canal or nerve canal. But apart from that, we also, because this is, we are achieving or hoping to achieve good primary stability, we need to place this implant in the best possible position to achieve that. So there are two views that we can use three-dimensionally. That makes it a bit easier. And this would be one of them. So we can see what part of the implant is going to be inside new bone. And then we can also see what part of this implant is going to be inside the socket, which will be grafted. Dr. McRae will take you through that. So this is one view. The other view that we also use that is pretty handy is when we look at the tooth and the implant together, and we can see how much of the implant is going to be tapping into new bone. And let me just mention this, not being a salesperson. These are pretty amazing implants. It's really amazing the primary stability that we get from both of them, whether we use the normal contact, as we see here, typically in D1 or D2 bone, and the contact S plus in D3 or D4 bone. It also does not limit us. In this specific case, I believe we had D3 bone, and we used a normal contact implant, not an S plus. And Dr. McRae still achieved great torque and a good ISQ value. But it's really easy for us when we plan these cases that we have access to both those implants in one system. And the fact that both those implants share exactly the same platform also makes it pretty amazing and easy to plan these cases. It's almost like making a statement. If it can be restored with an implant, it will definitely be able to be restored with a normal contact or a contact S plus.
Okay, so I'm going to go ahead and stop it there. You can see that the one thing that I want to just describe to you is that there's only one system out there that can do what he just showed you, and that is through Marius, his planning team, and their ability to be able to do this where they can virtually extract the entire root, be able to see exactly where it's going to be placed. When I say this is the most accurate way to place an implant, I'm telling you, there's not a more accurate way. And I've now seen it over and over with my patients. So this is what we get back from the lab. Here's our guide. Now, again, I want you to see this, where this is placed and how accurate we have to be. That's the key, is accuracy and confidence going into a surgery, knowing that you're going to be extremely confident if you just follow the plan and be able to make sure that you follow the plan and do the things correctly. This gives me a lot of confidence as the surgeon. Again, this is what we get from the lab. We're able to have our upper left. What we have is the temporary abutment, just in case that final abutment, we don't have a good enough stability. We can always kind of kick the can back and be able to say, all right, we're punting, we're going to go back to this temporary abutment. And I've done it with as little as 15 Newton centimeters and had great results because nothing's going to be in occlusion and it still seals the socket. There's no difference in the socket preservation between the temporary abutment and the final abutment. And then we also have the PMMA to be able to finish the case. And in this case, we used it to seed it and be able to take some pictures of it, but we did not use it in this case. So here is our surgical guide with our indexing. We did the PET, where the partial extraction therapy or the socket shield, and we took the majority of that root out and we just left that shield so that it would preserve that. That's a whole full day lecture in itself. It's just how to be able to do this. But if you use, this is before as we were talking, and I told Martis, I just hate doing this because it's just one of the hardest things to do well in dentistry is to do a really good PET. So we came up with a way of being able to do a true PET guide, and I'm going to show you that later in the presentation, how we do this and how this works to be able to use the PET guide. And then here is our surgical guide on the tooth. So here is my attempt at doing a PET. The hardest thing is staying in the middle of the canal. And I was off just a little bit, but it worked out just fine. And then we take different drills. I use a PET kit. You can get it from Salvin. It's a Howard Glockman kit, which I think is an absolutely fabulous kit to be able to help you do the PET in a very organized way and be able to get great results. So we then torque it like we showed last time, make sure that everything is lined up exactly where it needs to be, black line to black line. We then check our implant and then we do our bone graft. And we make sure and do the bone graft. And I really pack very tightly the bone around the implant. I want to make sure that it's very tight and it does not move anywhere. So as you can see, what we have here is we have our final abutment. We're able to put it exactly into place. It looks like what I want it to look like, which is a tooth that has been prepped, just a traditional crown prep. And this is what is going to be in the patient's mouth. We're hoping for the rest of their life, never to come out again. I torque these anywhere between 20 and 25 Newtons in the Biotech. And with Biotech's Contact and Contact S Plus, the connection is exactly the same. And what's nice is that it has a really nice Morris taper. You put that down, and when you completely connect that with about 20 to 25 Newtons, even if you take out the screw, it is not going to loosen. So there is no screw loosening with the Biotech implant system. To remove it, you have to use a removal tool, which is really easy to do. And it works extremely well. So here is us trying in the PMMA after the surgery. And so all we're doing is just trying it in, making sure that it fits. And that all of the contours of where we need to place the implant, it literally, I would say 80% of the time, I don't have to touch the implant or any part of it. It just literally, the PMMA goes on extremely well if I did everything that I needed to do. And number one, when you're doing these cases, the most important part of this is making sure that your surgical guide is completely seated. What we did in her case is we went ahead and prepped all of her teeth that we were going to do the new veneers on. And so we prepped from tooth number 5 to 12, and we placed new veneers. I think we actually went from 4 all the way to 12. And then so this is a specific way of being able to have a long-term temporary, and it's called a sandwich technique. And I don't have time to really explain how you do the sandwich technique, but the way that this is done, I want these temporaries in for 4 months while she's healing. And so we have to use a stronger temporary than just what is traditionally out there. And so it works extremely well if you do this sandwich technique. So here is what it looks like on the lingual surface. And then you can see that we've connected tooth number 5. Okay, this is 3 months later. If this material will degrade in color, it always does. And we, as you can see, that it loses its shine. Patients are ready to get something new. They're tired of not being able to floss. We absolutely recommend a water picks during this process and or some sort of water flosser. And this has worked really well in the past. Now, I can't emphasize enough the importance of this slide. I want you to just really take into account from the planning of what we had planned from the left slide with the blue outmark of the implant to where the implant ended up. I would venture to say, please show me something that is this accurate in dentistry today and where it was planned and where it finished. That is something that is very hard to do. It was a good PET because you can't really see the root section of it, and none of the gutta percha has been left behind. So it's worked well for the patient. Again, looking at the planning of where it started and where we actually finished. In actuality, in my opinion, we nailed it. Now, it's not necessarily, this is a team approach. And I love having a team that is supporting me. Again, I can't tell you how much confidence this gives me. And so when I talk to patients, that confidence is really, really important to be able to have. So here is our final, and this is how her veneers turned out. And this is what her implant turned out and looked like. She was extremely happy and she loved the outcome. So I just want to show you, this is our surgical room. And so this is the report that I get back from Marius and his team. And so we take that report, we tape it to our surgery room before the patient arrives. Everything is marked out, is exactly, it even gives you kind of a recipe of the drills that you need to use and when to be able to use them. So it just goes right through. And if you follow the recipe, it's pretty much right on. You got to know a few things technically to be able to feel what the bone is like and make decisions as you go. There's a 12 and a 14 millimeter offset, and that's the most important. And that's what that page is describing as the difference between the 12 millimeter and the 14 millimeter offset and when to use it and how to use it. So that's the planning. So now let's look at what happens if an implant isn't going to be a one stage, and we're going to finish with a final abutment. What do you do? So this is a case where we knew that the abscess was too big. It's in the very distal portion of the mouth. And so if it's in the very distal portion of the mouth, I don't recommend doing a one stage. So we knew going into this that this was going to be a 2-stage. This happens to be on a 90-year-old man who's my father. And he had a tooth. In fact, I got to tell you, it's kind of interesting when you've got siblings that say, don't worry about it, dad's too old. And I'm like, no, he's my dad. I'm going to definitely take care of him. And so I went ahead, we did the entire surgery. He had, this crown was failing. And as you can see, he had extensive decay. So we sectioned the tooth and we took out that upper molar. And then this is what we had. I didn't have much bone. We knew that we wouldn't. Again, I probably only got 15 or 20 Newtons. And then I did it as the best bone graft that I possibly could around that. Here's the implant placement. I want you to look at the socket because it's important to see the socket now. And then we're going to look at that socket again later. Remember, when we looked at the socket of the KOL in our last presentation, and the collapse that that whole socket had. Look at this, even though it's a two-stage, it wasn't a perfect extraction, but because you could see the rip that on that mesial section. Here is the bone graft with the implant, and that is the temporary abutment on top. So here's your temporary abutment that came from the lab. Again, we're trying to seal that socket so that we can keep that bone. This is day 1 of the surgery. This is 4 months later. He had a little bit of height and some resorption, but he did extremely well. The tissue looks really good. We still have a good amount of buccal bone. We take that out, and this is the socket that's left. We are mimicking what he had originally. He still has great buccal bone. I would venture to say he lost a little bit of papilla, but it is much better than if we would have taken the tooth out, done a bone graft, waited 6 months, 4 months, 6 months. Then we would have put the implant in. Then we would have waited again another 4 to 6 months. We would have had a tremendous amount of bone loss. Also, if we would have done the immediate implant and then we would just use the healing abutment, that socket would not look like that. And so what ends up happening is we take a scan body, we scan it with the scan body, we put the temporary abutment back in, and this is the final. Again, it's probably too white. I like white teeth. He was happy with it, and that is his final crown. Had great stability, and it's servicing him well to this day. Okay, so we're going to go through this case. This is a very difficult case. This patient came to us. She had been to 7 other dentists throughout the year. She's been dealing with this, I think she said, since she was 7 years old. She had major issues with her teeth. She had a bridge, and the bridge failed. So she had a flipper, a temporary partial that was made, and she just hated it, absolutely hated it. Now, with this case, if you want to get very technical, there's a lot of things that needed to be done. I talked to her about the importance of airway, expanding her airway, about the importance of getting her teeth more in alignment, improving her occlusion. In her case, what she wanted was teeth, and she wanted it as fast as she could get it. I then said, well, we can do an all-in process. Told her of what we would do and how we would do it. And out of all of she had been to oral surgeons and periodontists and specialists, and she decided to go with us, and we did the surgery. So when you look at this, again, I wasn't sure how the roots were going to be. We took our x-rays, we took our CBCT, we sent it in for the planning. Through the planning, this is what we saw. This is a case where it was tooth number, I think that was 7. 7 ended up needing a PET. And so this is a case where we went, hey, can we do a PET guide? And can we make this an easier process? Again, doing a partial extraction therapy freehand, very difficult. With a guide, it is 100 times easier. So this is the planning that we got with the 2 implants. We're planning on placing the abutments and then doing a bridge, temporary bridge, along with a veneers on 8, 9, 10, and 11, I think in 12. Here is the guide. This is the planning again of how the guide would go in. The other thing that we needed is, because she had a loss of teeth, we did not have good gingival support for what we were trying to do. So we created a gingival guide. And that gingival guide shows me exactly where I need to remove any gingiva that needs to be removed. Here is my surgical guide. So we place the gingival guide day of surgery, shows me where I need to remove that tissue. And then I just take a laser and I remove it. This is the PET guide. The PET guide is just a 2 millimeter drill, and it has the exact depth that I need to go. So I have different drills that go with this kit, and that shows me so if it's 22 millimeters, I go exactly to 22 millimeters, and that gives me my initial hole in that root. So what you're seeing here is the extraction on tooth number 4, the ovate ponic that we created with a Deca laser. We go all the way to bone. That's really important when you're doing a ovate ponic. You want to make that ovate portion of it all the way to bone. And it's really nice to be able to use a CO2 laser. This is then on tooth number, I think that's 6, 6, 7 area. So I guess it's 5, 6, and 7 because that other tooth is tooth number 8. So on tooth number 7, what you've got is the PET guide and the first attempt of going into that canal. So here is the PET guide all the way to the end of the root. And then I just take the kit and I start to remove that lingual section of bone. In a PET, partial extraction therapy, we want to leave a fingernail of bone all the way into the adjacent areas. And so to be able to hold up that papilla of bone, but we want it really, really thin. So this is the removal of the one tooth. And then here is the PET of tooth number, we'll call that 7. Fingernail is exactly what we're looking for. We then have to reduce the occlusal height of that fingernail of bone. And so what we end up with is this is the implants, and we were able to place the abutments on there. These are the final abutments, day 1 of surgery. Before we did put the abutments on, we got we used the penguin. We got the ISQ numbers. Now remember, my number that I want for my ISQ is 70. I want it 70 or above. That surgery I showed you today of tooth number 7 that we did today, our ISQ number was 75 and 76. So we had plenty of stability. On this one, we had 69 on tooth number 7 and 71 on the other tooth. But because they're tied together, I just decided, okay, I'm averaging them. Average is 70. And so we went for it. If they would have both been 69, then that's going against the what I feel like is stability. We probably would have used the temporary abutments. So it was really close. Here is the final abutment, day 1 of surgery. It looks, again, like somebody had prepped those teeth. That's exactly what I want them to look like. We have a great ovate ponic. Her tissue isn't perfect. I don't like the length of that tissue on tooth number 7. It's a little too high. It's right in line with the central incisor, which I don't really like that look aesthetically, but she was okay with that. And her lip line also showed that it was completely okay. So here is the preps that we did for this case. So we prepped the veneers. We used that same sandwich technique. And we got her temporaries to be able to hold everything together. The sandwich technique is really just a simple technique where we're taking traditional temporary material, and then we use Luxacrown as the base, and that Luxacrown material is rated for 2 years. So we're using the strength of the Luxacrown, and we're using the beauty of, we use Voco's material, their bleach shade. If the problem with the Luxacrown material is that it's just ugly, it's ugly, ugly. Their bleach material is like A2. I don't understand why they can't get it brighter. but I do love the material because it gives it strength. But so we use this sandwich technique, which I can show later in other situations. But here is the initial response. I think this is a week later. And here is what she came in with. This is what she left with on the lower right. She was absolutely thrilled. She loved it. Okay, and then here is her final, or no, this is her still in her temporaries after it's healed. And then these are the finals. So this is the finals after everything is seated. When you're going through the process of taking the temporaries off, you're looking at the x-rays to make sure that you've got good bone adaptation from the very beginning, and making sure that nothing has changed and you don't have radiolucency around your implants. And then you're looking for any movement. If there's any movement at all, you don't have enough stability. And so you can either give it more time, put the temporaries back on, but most of the time that's telling you that the implant did not integrate. And we don't get that very often, but it happens. So this is her final. And you can see from the final that we got great adaptation. The bone is extremely happy. The number one thing, though, is the tissue. We had really nice tissue response. I don't doctor my photos in any way. I want you to be able to see exactly what the outcome is on these cases. So here is her before, here is her after. Here is her before, full face, and her after. So one thing that I do with every patient that we do surgery on is we have like a photograph session. So let me kind of explain how this works. We put the veneers in, we put the finals in, and then we say, we'd like you to come back for final polish and pictures. And then we say, okay, wear something dark because it just looks better. And so that's what the kind of how we get them to come back. And we just want to make sure that the occlusion is right, that there isn't any cement that is feeling not correct to them. And then we do this interview. And this interview has become one of my favorite things to do. I sit down with these patients. I don't do great, as you watch all it is a black background. And I have my iPhone, and I just interview them. And they tell me their story. So I'll ask a couple questions like, can you tell me your story? How did you find us? And I just let them talk. Some patients absolutely do not want us to use it. We still do it, and we just don't use it. Other patients are like, oh, by all means, you can definitely use it. And in her case, she had no problem in being able to share her story. So here is her story. Okay, tell me your story.
Wow.
Tell me, how did you find our office?
I started out with a local dentist in my area out in Parma, and I wasn't real comfortable with what he was wanting to do after I lost my bridge. So I just got on the internet actually and searched and searched and searched. And then I called the office. I felt comfortable, so I made the appointment. Read a lot of reviews, looked on your Instagram, looked on your Facebook, did a little bit of homework. So first appointment, came in and I was in tears. I remember you asking me like, why are you crying? But it's very traumatic to go through mouth problems, teeth problems, and to lose your smile. And I lost confidence. So
How long have you been dealing with your teeth and your issues?
So at 13, this happened to me where a dentist had pulled an eye tooth that he was not supposed to pull. And then he had to pull the tooth next to it. So 13 years old, I had my first, they called them flippers. And now I am 62 and finally have it fixed. But it took me a long time to find somebody that I could trust and do something that was impossible.
And so you've had your flipper from 13
all the way to about 25. And then I had my first bridge put in. And then 10, 15 years later, I had another bridge put in, and then another bridge put in. So yes, the bridges were fine. But it broke. And so that's why I had to come to you. I never realized that implants would be, I guess, back then implants weren't there. So now here I am.
So you came to us and you had 2 broken teeth off the bridge, right?
Yes.
How many consultations had you gone through?
Only since out here in Idaho, I've been here 7 years, and it's at each dentist, they were telling me, I'd been to 3 different dentists in 7 years. We need to fix your bridge. We need to fix your bridge. Okay, well, when it breaks, I'm going to fix it, because I did not trust anybody to do it right. And that's a hard time. When you're working with your mouth, having to have surgery, it's very difficult. It's very stressful. I just didn't trust anybody. So when it broke, you don't have a choice. But then I went to another one. So total, probably at least 4 in the last 7 years. Before that, it was probably at least 3 or 4, but nobody gave me the confidence to do what you did.
And so what did we do?
You went really fast. I got really confused at first, and I thought, oh boy, he's really moving fast. So yes, you explained the procedure. I didn't quite understand the whole procedure, so I asked a lot of questions. I got my answers for the most part. I felt it was a little bit difficult, so sometimes the answers aren't always there to me.
Yeah.
So anyway, the day of the surgery, yeah, you explained what would be best for my smile. It would help my breathing. I was really hesitant about you removing like 6 good teeth or 5 good teeth of mine to put veneers over, but you did it. Right?
Yeah, you see the results. So you have 2 implants. You have an implant bridge. You've got about 5 or 6 other veneers, crowns to make everything match. And what do you think of your smile now?
I love it. Everybody loves it. They say how good they look. It's getting close to about 9 months and it's almost done. So I'm really happy about that. The office has been great. All the gals, the doctors, everyone's been great.
Good. If you were going to talk to someone and they were going to have to go through something like this, what would you tell them? What would be your advice?
I would just say, don't be afraid. Just go for it, because you have enough confidence to do a good job. And I think people need to hear that you're confident and that this is what's going to happen. And I also feel like if something isn't right, you guys will fix it.
Absolutely. Well, thank you. You've been awesome.
Thanks.
Yep.
So I can't reiterate enough the importance of having confidence with your patients. And the only way to get that confidence is to be able to learn a system like this. We feel like the all-in system gives anyone that utilizes the system can have that confidence, and then patients can see that from you. And for her, this was an expense. It was very expensive for her. But she picked me out of 7 other doctors, specialists, because I think that once you go through the process, you have that confidence to be able to place these implants and be able to do it in a way that I feel like is the most accurate system that is out there. And then to me, if there is a very accurate system, I feel like I owe it to my patients to be able to give that accuracy to them. We have some time left over for some questions. I've had a couple of questions already, and so for the time remaining, please ask any questions to be able to go through that. If I don't get any more questions, I've got a couple more cases I can go through, and be able to just be able to take the rest of the time. But let me answer a couple of questions first of all. I got this question right from the beginning, and it says, would you say that immediate implants are not for beginners in implant placement? No, I wouldn't say that. I would say that immediate implants are for beginners, but I don't know that I would do all in. What I would start with is just learning how to use surgical guides. I truly believe immediate implants are a great way to be able to learn. You got to be able to learn how to do socket preservation, how to do atraumatic extractions. And there is lots of different ways to be able to learn that. Scott is going to give you an opportunity to be able to learn it in a very cool environment and in an environment that's going to be able to learn all of the techniques to be able to do what we are showing. So I do think if I could go back, I would want to learn how to be able to do immediate placement, to do it correctly right from the beginning. So if you're a beginner, yes, I think absolutely you can do this. It was told to me there's different theories on should you learn how to do freehand without surgical guides first. I can understand the importance of that, and that's how I learned. I learned how to do freehand because the reality is that and now I would say, maybe 3 out of 1,000 times I can't use the surgical guide or something's wrong with the surgical guide. It just, for us, they're so accurate. We make it work with the surgical guide. But there are cases that it simply doesn't work, or a patient needs to have it almost immediately. That's where to learn how to do freehand is very, very nice. So, but again, the way it was described to me was, who learns how to ride a bike with their training wheels? It'd be like learning how to do learn how to use a surgical guide. You get your training wheels, and then you learn how to be able to do it freehand. I do think that that's the better way of being able to do it. Another question that came was, a question was, when doing the temporaries from 4 to 12, are you having this pre-made from the lab so that it's stronger than what a temporary would be? No, I don't want that to happen. So the way we do this is we have a wax up that is made prior to going into the surgery. We have the Siltec from that wax up, and then I want to be able to integrate around all of the material so veneers. There's no way to be able to have it pre-made I guess you could, and then you could just reline it, but what I get is a much more accurate adaptation. And again, the material that we're using is rated for up to 2 years. So it works extremely well. And then we can go around the gingival area and make that also work very, very well. Let's see here. There's another question. Let's see, where was this? Where would be the best way to learn about CBCT readings and to be able to implant planning without guides? That's a great question. There's a lot of different options that are out there. When you buy a CBCT, the one thing you want to make sure is that you get trained on how to use your CBCT. The problem with the training, in my opinion, is that they show you every bellow and whistle, and you kind of forget what you really need. And there's a few things that you need learn how to be able to manipulate on any of the CBCTs. I'm going to tell you, there is most of the CBCTs now have really good images, but they're not all great. And so if you want to know what a good CBCT is, call someone like Marius and ask him who has the best CBCTs and what's the best images, because he can tell you from seeing a whole bunch of different ones. He can actually tell you the ones that he recommends. That is it. Okay, I've got 4 minutes. I'm going to show you. Here is some info that you can get from us and how to contact us. Okay, so if you look, this patient came in, she broke tooth number 8. I'm going to go through it fast. She broke it. For 3 years, we re-cemented it and re-cemented it, re-cemented it. And finally, she's like, okay, I'm ready for the extraction. This is what we went through the planning. We knew that the root was too far towards the buccal, so we had to do a partial extraction therapy. Here's the 3 guides that we got. The 3 guides with the in the upper right, you can see we've got the temporary abutment, the final abutment. So we have the occlusal reduction guide to be able to reduce that occlusal segment to make sure that the other guides will fit. So we reduce that. Here is our partial extraction guide. After we did the partial extraction first, the initial drill, we remove that lingual bone. We leave just a little bit of bone left. We want to make sure as we put the implant in that everything is lined up. As it is lined up, we make sure that we got below the black line, place the implant, do the bone graft. This was a difficult one because we had to get really close to that other implant and stay away from the other root. But if you can see this looks just like her natural tooth. That's what we wanted. She has an implant on the other tooth. That's an old technique where they use stark white. We don't want that anymore. We want it to look like her other roots. This was what she left with for 4 months, and this is her final. Now, again, this is really difficult to be able to see the tooth number 8. The crown does not go down all the way to the gingiva. That's okay. It actually looks really good. She was very happy aesthetically. And here's her before and her after. Okay, thank you so much. I'm going to put that one slide back on. We are out of time. It was great to be with all of you. And I hope you learned something tonight.